Hello everyone and welcome to Blood and Hematology YouTube channel. This video is about diagnostic criteria and blood and bone marrow morphology of acute myelomonocytic leukemia, AML-M4 and acute monocytic monoblastic leukemia, AML-M5. Acute myelomonocytic leukemia, AML-M4, is characterized by granulocytic and monocytic differentiation, and the presence of myeloid and monocytic cells in the peripheral blood and bone marrow. The M4 subtype accounts for 15 to 20% of cases of AML and is more common in older individuals and slightly more common in males. Diagnostic criteria of AML-M4 include: blasts comprise 20% or more of bone marrow nucleated cells and 20% or higher of bone marrow non-erythroid cells. Bone marrow granulocytic component, myeloblasts to polymorphonuclear leukocytes, comprise 20% or more of non-erythroid cells, and significant monocytic component, as shown by one of the following. Bone marrow monocytic component, monoblasts to monocytes, comprise 20% or more of non-erythroid cells, with peripheral blood monocytosis. Bone marrow monocytic component comprise 20% or more of non-erythroid cells and confirmed by cytochemistry or increased serum or urinary lysozyme concentration. Bone marrow resembling AML-M2, with peripheral blood monocytosis and confirmed by cytochemistry or increased serum or urinary lysozyme concentration. In M4 subtype, myeloperoxidase stain is positive in at least 3% of blasts. Chloroacetate esterase is positive in granulocytic cells and weak in monocytic cells, and alpha-naphthyl acetate esterase is positive in monocytic cells. A double esterase stain for chloroacetate esterase and alpha-naphthyl acetate esterase is a convenient method for demonstrating the pattern of differentiation and saturation in M4 AML. In AML-M4, the cells are positive for the myeloid antigens CD13 and CD33, and the monocytic antigens CD14, CD4, CD11b, CD11c, CD64, and CD36. Monoblast is a large cell with round to oval, folded or indented nucleus, fine and delicate chromatin, one or more prominent nucleoli, and abundant light blue to gray cytoplasm. Fine azurophilic granules, vacuoles, and pseudopods may be present. Promonocyte is also a large cell with an irregular or convoluted nucleus and fine to lacy chromatin, but coarser than the monoblast. The nucleoli are present but not prominent. The abundant cytoplasm is light blue to gray, with usually more prominent granules compared to monoblast. Vacuoles may be present. AML-M4 patients often present with significantly elevated leukocyte count, elevated circulating monocytes, anemia, and thrombocytopenia. Myeloblasts, promyelocytes, and other immature myeloid precursors, and also monoblasts and premonocytes are present. Or rods also may be present. Peripheral blood film of a patient with AML-M4 showing a myeloblast, 2 premonocyte and a lymphocyte. Peripheral blood film of a patient with AML-M4 showing a myeloblast, a monocyte, a premonocyte and monoblasts. Peripheral blood film of a patient with AML-M4 showing a dysplastic neutrophil, a promonocyte, and 2 monocytes. One has large vacuoles. Peripheral blood film of a patient with AML-M4 showing a dysplastic neutrophil, a lymphocyte, and 2 monoblasts, one with pseudopods. Bone marrow film of a patient with AML-M4 showing 2 myeloblasts, a promonocyte, and 3 monoblasts. A normoblast is also present. Bone marrow film of a patient with AML-M4 showing leukemic cells of monocyte lineage, with abundant cytoplasm and delicate chromatin. Bone marrow film of a patient with AML-M4, showing monoblasts. In M4 AML, the granulocytic differentiation is usually along the neutrophil pathway, but in some cases, it is eosinophilic, basophilic or both. M4EO subtype of AML is associated with chromosome 16 inversion and less often, translocation 16:16. These genetic abnormalities are diagnostic of AML and do not require a 20% or higher blast count. In AML M4EO, flow cytometric immunophenotyping shows both granulocytic and monocytic differentiation. Myeloperoxidase and nonspecific esterase stains are positive. Specific esterase is weakly positive in abnormal eosinophils. In AML M4EO, the eosinophils are notable for the presence of basophilic and eosinophilic granules. Despite the bone marrow eosinophilia, peripheral blood eosinophilia is unusual, and sometimes peripheral blood eosinophils appear cytologically normal. In some cases, mature eosinophils may be hyperlobulated, or with large and folded nuclei. Peripheral blood presents myeloblasts, promyelocytes, and other immature myeloid precursors, and also monoblasts, promonocytes, and monocytes. Or rods may be present. Peripheral blood films of a patient with AML M4EO, showing eosinophils that have a mixture of granules with eosinophilic and basophilic staining characteristics. Peripheral blood films of a patient with AML M4EO, showing eosinophil precursors with abnormally basophilic granules. Bone marrow blast cells are variable in size and shape, with prominent cytoplasmic basophilia. Some are monoblasts or promonocytes, and some are primitive cells with occasional eosinophil granules. Bone marrow eosinophilic cells show dysplasia and prominent pro-eosinophilic granules, which are basophilic in their staining characteristics and larger than normal. Or rods may be present. Bone marrow film of a patient with AML M4EO showing eosinophil precursors with large and abnormal basophilic granules. Acute monoblastic monocytic leukemia, AML-M5, comprises about 15% of AML cases and is most common in younger individuals. In AML-M5, extramedullary involvement, including skin and gingival infiltration, central nervous system involvement, and bleeding disorders, disseminated intravascular coagulation, and increased fibrinolysis are common. In AML-M5, blasts comprise 20% or more of bone marrow nucleated cells and 20% or higher of bone marrow non-erythroid cells. Bone marrow monocytic component comprises 80% or more of non-erythroid cells. In M5 subtype, myeloperoxidase stain is negative, and nonspecific esterase is strongly positive, but is weak or even negative in 20% of cases. AML-M5 cells are positive for the pan-myeloid and monocytic antigens. CD34 antigen is usually negative. M5 AML is subdivided into M5A AML, acute monoblastic leukemia, and M5B AML, acute monocytic leukemia. In AML-M5A, monoblasts comprise 80% or more of bone marrow monocytic component. In AML-M5B, monoblasts comprise less than 80% of bone marrow monocytic component, and usually there is a profound peripheral blood monocytosis. M5A and M5B are cytogenetically and genetically distinct. Peripheral blood film of a patient with AML-M5A, showing 2 monoblasts, one with pseudopods. Peripheral blood film of a patient with AML-M5A, showing a monoblast and a monocyte with a nucleus of abnormal shape. Bone marrow film of a patient with AML-M5A, showing monocytic cells. Monoblasts are predominant. Bone marrow film of a patient with AML-M5A, showing a monoblast and 2 normoblasts. Peripheral blood monocytosis in a patient with AML-M5B. Bone marrow film of a patient with AML-M5B, showing monocytic cells and a myeloblast. Thank you for watching this video. If you liked this video, to give it a thumbs up and share it. Do not forget to subscribe to the channel, if you still have not. You can click on the bell to receive notifications whenever a new video is uploaded.